Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, November 13th, 2000. It says on the slide 2020, but we're actually still in 2019. We've been so excited about planning for our 2020 lecture series, we got ahead of ourselves. But this is for the RN and Allied Health Lecture Series for 2019. Just a few things to go over, and then we'll meet our guests and get started. Let's see. If you are having any technical difficulties at all, please call us right away, 919-445-1000. We do have people standing by who can help you out. We can also be contacted via email, unccn@unc.edu. You can find out all sorts of things about us, our past and future events, our learning portal, and of course we do have a learning portal. And so if you miss this event or have to leave early, if you want to recommend it to colleagues, and please do, they can go to the portal anytime within the next year. Watch the lecture, and it'll be up just a few weeks after this live event, and then take a test. And as long as you pass the test, you can get one of the different types of certifications that we have, and that's ASRT and ACPE and CNE certification for today's presentation. All right, so let me tell you a few other things. There's information about the live lectures, the self-paced lectures, our media site library, and we also have a YouTube channel. We will be using Poll Everywhere today, and I'm going to step it up a little bit with Poll Everywhere today. So there are multiple ways you can join. Let me tell you about that if you haven't done this. You can go to pollev.com/UNCCN from any device that has a browser connected to the internet, and as the questions appear, you'll see them in that browser window. You can answer these questions anonymously, and then we'll see the results right here. At the end, you'll have an opportunity to ask questions, and then we'll post the questions, and our guests will answer those at the end. I'm going to do something a little new today, which is, unless there's an active question on the board, we'll make that link for Poll Everywhere open for the questions at the end. So that way you can start submitting your questions early. If you think of a question 5 minutes into the presentation that you want to ask, go ahead and put it there, and we'll ask that of our presenters at the end. If you want to use the texting way to get into Poll Everywhere, just type in the numbers 22333. Well, that's the message where you'll be sending the message with in the to field, in the message field, UNCCN. So UNCCN going to the number 22333. You'll get a message back saying you've joined, and then you're in. There's also a Poll Everywhere app if you want to use that. Super easy. Just download it, put in the letters UNCCN. It's free, and I've been using that more, and that works well. All right. This is our poll for today. Which of the following statements is false? Tobacco use is the leading cause of cancer and death from cancer. That's A. B. People who use tobacco products have an increased risk of cancer. C. People who are regularly around secondhand smoke have an increased risk of cancer. Or D. Tobacco products and secondhand smoke do not have any chemicals that damage DNA. So this should be kind of a softball, but that'll go ahead and get you using Poll Everywhere. And without further ado, I'm very pleased to introduce Ellen Ruebush and Colleen Meyer. So thank you both for being here today. Let's see what we know about you. Ellen, you received a Master of Social Work from UNC in 2014. Great. And worked in community mental health, treating adolescents and adults with mental health and substance abuse problems. Licensed clinical social worker and licensed clinical addiction specialist, and in 2018 joined the tobacco treatment program as a tobacco treatment specialist at the Cancer Center. Okay. Great. And what's one thing we should know about you that didn't mention there?
Yeah, so one thing that is not there is that my family and I have a tradition of taking an annual trip to Europe. Wow. Which is a luxury, of course. Yeah. Did not keep that tradition this year, but hoping to start it up again next year.
Well, I hope you do. Great. Thank you so much for being here. And Colleen, graduated from Miami University with a degree in anthropology, and from Ohio State University in 2012 with a master's in social work. Great. And experience in community mental health, providing trauma therapy to survivors of violent crimes and traumatic events, as well as experience in treating substance abuse needs in a residential setting. Great. And a licensed clinical social worker, and you joined the tobacco treatment program in 2018. All right. Well, and what's something we should know about you?
My new favorite podcast to listen to is The Happiness Lab.
What do you like about it?
Yes. It's just really good to get you thinking about how to generate long-term happiness in your life.
Great. Good to know about. I'll check that out. Well, thank you both so much for being here today. Let's take a look at that poll. And we've already had people answering this. So we've got a few with A, a very small percentage with B, and then a bunch of folks with D. How are they doing?
Those folks are doing pretty well.
Okay. Okay. Is there any, we've got some with A. Is there any reason you think they might have gone with A?
I'm wondering if it's just, I think tobacco use, people may be thinking that it's limited to like certain types of cancer, so when they're thinking about a broad range of cancers, it's possible they're not thinking about that.
Gotcha.
Yeah.
Okay. Well, it looks like we've got lots of folks using poll everywhere. This really makes the whole presentation more interesting to have you all interacting as an audience with our guests here. So thank you so much for doing that. Tobacco use treatment in cancer care, and I'll go ahead and pass this on and pass the mouse on as well.
Thank you.
All right. Thanks so much.
Okay, so today we're here to talk about tobacco use, specifically implications with regards to treating patients that have cancer. And the reason we feel this is an important topic is about 80% of Americans that smoke see a provider on an annual basis. Unfortunately, only about 70% of those patients also want to quit smoking. However, we know that less than 50% get asked about their tobacco use, and less than 25% receive the standard of care treatment that we know works well and works best for treating tobacco use. So our goal today is to really increase your confidence with talking to patients about their tobacco use and communicate some ways to effectively treat tobacco use disorder. Patients that continue to use tobacco throughout their cancer care experience quite a few implications throughout the spectrum. We know that in general, continuing to use tobacco can increase risk for secondary cancers. It affects almost every organ throughout the body system. With regards to surgery, patients that continue to use tobacco can experience a wide range of complications. It particularly affects wound healing. Nicotine can really restrict blood flow and blood delivery to wound sites. And we know that with radiation as well, it can increase treatment side effects. Things like fatigue, dry mouth, loss of taste. All of that can become exacerbated by continued tobacco use. Patients that are receiving chemotherapy treatments similarly can experience an increased intensity or frequency of side effects. Tobacco can interfere with the treatments or the drug medications that they may be getting for their chemotherapy. It can also increase fatigue, weight loss, and it can suppress their immune system, which is already, of course, weakened by their cancer and their chemotherapy. And in the world of palliative care, patients that continue to use tobacco struggle with pain management, and often they report a lower quality of life. We also see many patients that use tobacco have an increased rate of needing home oxygen support, which of course becomes even a safety risk with regards to smoking and using or wearing an oxygen tank. If we're able to work with a patient to either reduce or hopefully become completely tobacco-free, some benefits they may experience include increased chances of survival. It can decrease their risk of recurrence of their primary cancer. It can also decrease risk of future secondary cancer development. Speaking to kind of the last slide, treatment side effects can be minimized, hopefully, as well as complications from surgical procedures. We often see and really communicate with patients about the fact that they're already going through treatment, and if they're able to quit tobacco, it can make their treatments more effective and more timely, and our goal, and I would hope patients as well, is to make those treatments as effective as possible. Many patients with cancer also have comorbid pre-existing conditions, and continued tobacco use only exacerbates those further. Things like COPD, diabetes, cardiovascular disease. And so really, we work a lot with patients to help them understand that their tobacco use and reducing or quitting that can have positive ramifications across a multitude of issues that they're experiencing. And patients that that can quit tobacco, even at end of stage of life, report an increased quality of life. And that, I think, is related to better pain control, as well as a decreased experience of stigma and shame with regard to their no longer using tobacco. Treating tobacco use is much like any other addiction or substance use disorder. It's a two-pronged approach. We know that tobacco use is a chronic brain disease, which requires us to treat it, both the physiological symptoms as well as the behavioral issues. Treating one of these independently is effective, but they become even more so when you combine them together. And it's our belief that with every quit attempt, every patient should be encouraged and advised to employ strategies from both of these realms, unless for some reason there's a contraindication not to. Doing both approaches is going to have greatly increase a patient's chance of becoming tobacco-free, hopefully. And, you know, through polling, many patients and many studies have looked into what patients want with regards to their tobacco use and working with a provider. Most patients report that they are already well aware of what the hazards are of their continued smoking or tobacco use. And what they want to hear from a medical provider is options and choices. They're not typically offended if you bring up their tobacco use, but what they don't want is a sermon or a lecture or criticism as to the effects that their tobacco is having on their health. Most often they've already heard it many times, and if quitting was simply that easy, they would have done it long ago. And there's many in the field that believe failing to address tobacco use is actually leaning towards being unethical, that simply not bringing it up or not addressing it with a patient is kind of a tacit support of continued tobacco use, which may feel like a strong stance, but I think it's food for thought as to the importance of bringing up this issue with every patient at every visit. And so in the world of tobacco use, the 5 A's are sort of what we have as the standard of care. It's a brief intervention that can help providers sort of structure a conversation with a patient. The more of these A's you can employ, the greater the chance of a patient's success. If you're able to get all 5 of these A's, we can hopefully increase a patient's chance of becoming tobacco-free up to 30%. We know that most patients quit unassisted at a rate of about 3 to 5%. So as you kind of progress through these 5 A's, the more you can integrate and employ, we up those odds significantly. And those 5 A's are to ask about tobacco use status, every patient, every visit, and document what that status is. Things can change from visit to visit, and it's important to continue to bring it up and bring it to the forefront of the patient's mind, because from one visit to the next, their motivation may have changed significantly. Advise, urge every tobacco user to quit in clear, strong language, and the more personalized you can make it, the better, with regards to comorbid conditions they may be already experiencing, or their specific plan to their cancer treatment. If you can loop that in, it feels personal, and it feels as if you're invested in that patient, rather than just giving generalized kind of canned responses. Assess willingness. Again, as we were saying, willingness and readiness can change, at a moment's notice. And so always sort of checking in and not assuming that just because the patient wasn't ready last time, they won't be ready this time. Assist patients with getting connected to counseling or support, making recommendations for pharmacotherapy. And if you don't have those services in-house, really knowing what your resources are, either within your agency or within the hospital, or sending them to the North Carolina Quitline. And arrange follow-up. Make sure that somebody's going to be in touch with that patient to make sure they got connected, that they were able to pick up their prescriptions. That continues to convey the importance even beyond that first conversation. So certainly there are ways you can ask and not to ask a patient about their tobacco use, which is going to hopefully increase your odds if you can ask it correctly. Ways we would advise you not to ask are questions such as, "You don't smoke, do you?" Often what a patient will hear is, if I say yes or I endorse that I'm still smoking or using tobacco, this person may judge me, or I'm going to get a label in my chart that's going to stick with me throughout my course of treatment. Questions such as, "Are you a smoker?" seem innocent, but again can convey stigma and shame, and again this idea that the patient might be put into a label as a smoker, which in our society I think now has a negative connotation for sure. Or are you still a smoker? You know, if the patient's been trying since the last time you saw them and they haven't been able to successfully cut back or quit, they may be afraid that they're going to disappoint you, or that they will be perceived as a failure for not having successfully made any progress since the last time. Ways you can ask. Be straightforward and objective. Have you ever smoked cigarettes or used other tobacco products? If the patient says yes, inquiring simply about the frequency. Do you smoke every day, some days, or not at all? Our standard kind of question too is, have you smoked even a puff in the past 30 days? And that normalizes anything from one puff to daily frequent use. And of course, if the patient says, no, I've never smoked or used tobacco, or I've quit, trying to figure out when was the last time they did smoke or use tobacco. And that opens the door to congratulate them on success. We really believe that any amount of time tobacco-free should be acknowledged, because it's certainly a huge achievement. And advising is similar. We want the language to be clear and strong. Saying something like quitting tobacco use is one of the most important things you can do for your overall health. Incorporate empathy. Make sure you understand how difficult this is and the fact that many patients try over 10 times to quit before they're successful. So really helping to normalize this patient's journey. Offer help. We have effective resources such as medications and the Quitline, and with regards to us, the tobacco treatment program, and be open to hearing what their thoughts are. Often it's simply taking that extra step and asking, what are they afraid of about quitting, or what is it that keeps their confidence so low? Might be something nobody's ever asked them before, and that could really open the door to a new experience with quitting this time. So putting it all together, it would sound something like, quitting all tobacco use is one of the most important things you can do for your health. I understand that quitting can be difficult, and I'm here to support you. We have many effective resources, such as medications and the North Carolina Quitline, that can help you succeed. I'd like to hear your thoughts about stopping or cutting back on your smoking or tobacco use. And assessment. Again, the more A's we can incorporate into this conversation, the greater the chances of a patient's success. So with regards to assessment, always sort of putting yourself in their shoes. Consider the pressure they feel every time they're asked about it. Are you ready to quit smoking? The patient might worry, if I set a quit date and I don't succeed, they're going to perceive me as a failure, or what's the criticism or the lecture I'm going to get when I come back next time? And really, again, putting yourself in their shoes and wondering how to structure that conversation that will be felt to be most supportive to them. And your best bet is to always go with open-ended questions. Ones that can't be answered with a simple yes or a no are going to really keep that conversation flowing and feel natural. It's going to feel more authentic to a patient as well. Questions such as, what are your thoughts or feelings about reduction or cessation? what do you not enjoy about smoking? And quite often asking, which nobody frequently does, what do you still enjoy about it? That question will really open the door to exploring potential future obstacles the patient may experience. If they talk about it reducing their stress or helping them deal with their depression, that's going to, in the back of your mind, give you some ideas as to maybe some withdrawal symptoms that patient might experience and be ready to help coach them through that. And also asking what could be different or better about your life if you were no longer smoking or tobacco-free. Usually the most common answer, and if they can't think of one, the easiest one to give them is money that they'll save. And from there, that can really open the door and get the ball rolling with them thinking of other benefits that would come from envisioning their life without tobacco. This might be challenging for many patients. They've probably smoked or used tobacco the majority of their life. And so for some of them, it may be quite difficult to think of what their life was like without it. And I think that's a really interesting space to explore with a patient if you have the space and the time to do so.
Okay. I am going to be talking about the next A, which is assist, and involves two sort of strategies. As Colleen mentioned, treating tobacco use has both a behavioral component and a physiological component, and so treatment has to address both. So the first part of assist is counseling. You want to assist the patient with identifying triggers for their smoking. A lot, if you think about the average smoker, they smoke about a pack a day, that's 20 cigarettes a day, and that's about 200 to 300 puffs on a cigarette a day. So they're doing this very frequently, more than they're doing almost anything else in their lives. So smoking unconsciously becomes linked to certain triggers, certain moods, and certain situations. So it's important to figure out what those are so that then you can develop a plan for how to handle those. Some of the more common ones we hear are when someone's in the car driving, right after someone's having coffee or after a meal, when they're stressed is a very common one. We feel, and this is so important for patients who have cancer or are undergoing treatment, because stress is obviously a daily that's a daily part of their lives, and so it can often feel overwhelming to tackle smoking at this time, but it's so important for their treatment. So stress is something that has to be at the forefront of your minds when you're talking to patients with cancer. You want to assist the patients with developing strategies to handle those triggers. So drinking a glass of water, breathing deeply, going for a walk, any sort of activity they can engage in to distract themselves from the urge to smoke. It's also about removing triggers from your environment as much as possible. So if someone who smokes, if you have ashtrays around the house, every time you see an ashtray, that's an unconscious trigger to smoke. So getting those things out of your space, out of your environment. Sometimes I'll tell people, a lot of people I know keep cigarettes like in their pockets, and so telling them to not keep their cigarettes there, put them on top of your fridge or something, so they're not quite as accessible, and hopefully gives people a chance to stop and think about what they're doing before they light up the cigarette. A lot of people say that before they've even noticed what they're doing, they've got a lit cigarette in their hands. Some of the other strategies have to do with keeping your hands and mouth busy. People talk a lot about the hand-to-mouth action being very challenging. They just get used to holding something or moving it from their hand to mouth. So we talk about some people like to hold straws. They cut off straws to be the size of a cigarette, and they'll hold that in their hands or hold that in their mouth. Toothpicks, any sort of like mint or lollipop or sucker in the mouth helps. So you have to be creative. I like to tell people too that one strategy is not going to fix the whole problem. A lot of times it's about combining strategies and really tailoring that to the person, and sometimes being very creative about it. You want to then, once you've kind of understood the triggers and the strategies, you want to help the patient link those things. And one of the things we find most helpful is if-then planning, which is If a trigger happens, then the strategy. So helping, I like to sort of help patients think about maybe the top 3 triggers they could encounter. Could be stress, could be after a meal, then coming up with 3 strategies to try and pairing those together. If I feel stressed and want to smoke, then I will practice deep breathing. If my friend tries to smoke in front of me, then I will leave or ask my friend to smoke somewhere else. And so sometimes you can either just verbally go over these with patients. Sometimes it helps to have patients write them down to take with them. But whatever conversation you have around this is helpful.
All right, and here's our first poll. Oh, somebody knew the answer before, or thought they knew the answer before we even had the question. All right, so which is not a helpful strategy for managing urges to use tobacco? And would that be A, sucking on mints, B, holding an unlit cigarette, C, munching on a carrot, or D, breathing deeply? And I see a bunch of answers coming in. So again, this is which is not a helpful strategy for managing urges to use tobacco. So Ellen and Colleen, how are they doing?
Quite well.
Doing very well.
Good.
Doing very well, yes.
All right.
Should I give the answer now?
Yeah.
Okay. So the correct answer
I'm going to guess based on what you said, but it's B.
It is B,
Okay.
holding an unlit cigarette.
Okay.
So sucking on mints is actually a helpful strategy if you're concerned about sort of sugar-free items are fine. Holding an unlit cigarette is risky, especially because I said a lot of people have lit the cigarette before they've noticed. But the interesting thing is we have had patients tell us that they use that as a strategy, but it is not one we would recommend. It's risky.
Yeah, I can see.
Yeah.
Okay. Very good. All right. Well, thank you.
Okay, yeah. So the other part of assist that I mentioned earlier is pharmacotherapy. And so this really is going to address the physiological aspect, the dependence on nicotine, which is an important component in tobacco use disorder. So tobacco cessation medications support a patient in making a change by decreasing withdrawal symptoms like craving, irritability, and depression. So it's important to encourage all patients to use tobacco cessation medications if they're attempting to quit smoking, unless there's some contraindication. So we consider this standard of care. All patients who are trying to quit or cut down should be using a medication. Some of the symptoms of nicotine withdrawal. Nicotine, again, is the part of cigarettes and tobacco that is addictive. It's not the most harmful part of tobacco, but it is the part that keeps people coming back to smoking. So if someone were to go cold turkey, they'd begin experiencing irritability, anxiety, trouble concentrating, depressed mood, difficulty sleeping, increased appetite and weight gain, and cravings and urges to use. So most of these symptoms appear within the first 1 to 2 days. They peak within the first week, and they usually start going down after 2 to 4 weeks. But that's why that first period, those symptoms can be so acute in that first period that a lot of people have trouble staying quit more than a day or two. You know, as soon as that irritability in particular starts to crop up, they just go back to smoking or using tobacco. And a lot of times family members will say this. I had one patient tell me that his wife had asked him to start smoking again because he was really irritable. So it's important to be able to manage these withdrawal symptoms and give people a chance at being successful in quitting. I sort of like to frame it too as quitting tobacco is like you're fighting 2 battles. You're fighting the nicotine addiction or dependence, and you're also fighting the behaviors and the triggers and urges in your environment. So if you're not using medications to handle the nicotine addiction, you're sort of fighting, all your energy is going to 2 areas. You're splitting your energy, which makes it really hard. If you can use the medications to help manage the addiction, the dependence, then patients can focus all their energy on the behavioral change. So it's sort of giving them that energy to shift their attention and focus on behavior change. There are 7 FDA-approved medications for smoking or tobacco cessation. There's nicotine replacement therapy. You've got the patch, the gum, the lozenge, the nasal spray, and the oral inhaler. Then you've got Varenicline, and then you've got Bupropion. Those are your 7 FDA-approved medications. Some of these are available over the counter, and some are available by prescription only, and some both. Using pharmacotherapy triples quit rates, so it is an essential component of treating tobacco use. What we consider standard of care in pharmacotherapy, there are two options. The two best options are 12 weeks of combination nicotine replacement therapy. That means a short-acting with a long-acting, and I'll go over what those are. But so combining a short-acting nicotine replacement therapy with a long-acting product, or the other good option is 12 weeks of Varenicline. So those should be your first go-tos. And the reason we talk about pharmacotherapy quite a bit is because even if you're not prescribing or not able to prescribe, this will help you make recommendations to patients, help you understand what they've used before and maybe how they could use it again to be helpful. So I think it's valuable, even if you're not prescribing, just to be aware of what we consider standard of care so that you can make helpful recommendations. So as I mentioned, those are the two standard of care pharmacotherapy items. There is strong research supporting these as the most effective options, and no patient should receive anything less than this or different from these two things unless there's a contraindication. So these are your go-tos. Nicotine replacement therapy, or NRT. The advantages of using this are that it provides the addictive substance nicotine without the other toxins and carcinogens that come in tobacco. It does not introduce a new substance into their body, so some patients who are worried about adding a new medication or something like that in, nicotine replacement therapy is great because they're already getting nicotine with the cigarettes or the tobacco. You're not adding anything new. It has minimal side effects with proper usage. It allows people to dose flexibly. You can see in the picture here we've got different steps of patches, and they can gradually reduce their nicotine use, and it attenuates weight gain. Some of the side effects that you'll see with the patch are skin irritation, nausea, dizziness, or insomnia. The nicotine gum and lozenge, nausea, headache, mouth soreness. Nicotine inhaler, throat and mouth irritation or cough. And the nicotine nasal spray, nasal and throat irritation, runny eyes and nose, and cough. So as I mentioned, the reason we recommend combination NRT is because, as I mentioned, there are two types. There's long-acting and there's short-acting. So long-acting, the long-acting option is the nicotine patch. Then you've got 4 different short-acting options, which are gum, lozenge, nasal spray, and oral inhaler. The long-acting nicotine replacement therapy gives the patients a consistent low-level amount of nicotine. It stimulates those receptors at a low level. And this, I know this chart is a little hard to see, but the basically the green line that spikes the fastest is a cigarette. The blue line that has the other higher spike is smokeless tobacco. And then everything down below, those are all your nicotine replacement products. So you can see that cigarettes have a really high addiction potential because of that quick spike into the bloodstream, whereas all of the nicotine replacement therapy products are not going to give you that spike. They don't have the same addiction potential as cigarettes. So if patients are concerned about that, these are not products that people get addicted to. It's products that people can use as they work on quitting and then can eventually get off of. So the short-acting nicotine replacement therapy comes in because it helps manage urges that arise due to triggers during the day. So we call these breakthrough cravings. So someone would be using the nicotine patch and feeling okay, but all of a sudden maybe they get in their car, and that's where they used to smoke a lot, so they have a breakthrough craving. And that's when we would recommend someone pop in the nicotine gum or lozenge. Those are the two we go with most frequently to help them get through that craving and get on to the next moment. And so we'll have patients keep those products. I have patients keep them in their car, in their cup holder, so they're available in those places where the triggers are. In terms of dosing, again, this is helpful whether you're prescribing or not to understand. One pack of cigarettes has 20 cigarettes in it. The nicotine patch comes in 3 different strengths: the 7 milligram, the 14 milligram, and the 21 milligram. And the nicotine gum or lozenge come in 2 dosages: the 2 milligram and the 4 milligram. So everything is based, we do what's called nicotine matching. So you want to match the dose of the nicotine replacement therapy to the amount of nicotine they're getting in their cigarettes. If you go too low, it's not going to help at all, and that's actually what most patients do. They're underdosing. So you can see that if you have less than a half pack a day, you're going to do the 14 milligram patch and the 2 milligram gum or lozenge. You'll notice that we don't really, even though the patch exists in a 7 milligram, we don't really use that. The 7 milligram is so little nicotine that it's not going to do much for anyone. So we use the 14 and the 21. If someone's up to over half a pack to a pack a day, then they're using the 21 milligram patch with the 4 milligram gum or lozenge. If you're getting to a pack and a half a day, we do recommend that patients double patch. So this is not something that most people have tried before. If they were to go and get nicotine patches in a store, they divide it by step 1, step 2, step 3, where step 1 is 21 milligrams, and then it goes down from there. So most patients think they have to start with the step 1. If you're smoking over a pack a day, you need to be starting with more than the step 1. And so that's where combining nicotine patches comes in. It's safe and it's effective. So for someone who's at a pack and a half a day, you're going to combine the 21 milligram patch with the 14 milligram patch, and then added the gum or lozenge. And finally, if someone's at more than a pack and a half a day, then you're going to do 2 21 milligram patches with the 4 milligram gum or lozenge. For smokeless tobacco, which we see less of, but still do see in our work at the North Carolina Cancer Hospital, dosing similar. We do nicotine matching again in this dosing. So if someone's using less than 2 cans or pouches per week, we're starting with a 14 milligram patch daily with the gum or lozenge, 2 to 3 cans or pouches a week, 21 milligram patch daily plus the gum or lozenge. So again, the use, just to be clear, is per week. The smokeless tobacco is per week, but you're prescribing daily dosages or recommending daily dosages of nicotine replacement therapy. And then finally, if someone's over 3 cans or pouches per week, you're going to do 2 21 milligram patches daily with the gum or lozenge. Varenicline, which is the other standard of care option I had discussed. The advantages, this is a prescription medication. Advantages are that it blocks nicotine, which decreases the pleasure of smoking, but it still stimulates enough of those receptors so that some dopamine is released. And dopamine is the neurotransmitter that gives people sort of the feeling, the feeling of pleasure. So it blocks them so people who smoke don't feel that same pleasure, although they're getting just enough stimulation to feel okay. And Varenicline works really well for people who are able to tolerate some of the side effects. So some of the side effects are nausea, insomnia, headache, and vivid dreams. As you can imagine, these are particularly of concern for patients with cancer, because a lot of times whatever treatment they're on is already giving them some of these side effects, so there's some anxiety around adding to that. So if someone's certainly nervous about that, we wouldn't recommend it, or we could recommend starting with a really low dose or trying it out, and if it's really causing problems, then taking it out and going to nicotine replacement therapy. But for people who are able to tolerate the side effects or don't have side effects, it works very effectively. I've had a number of patients who are quit within a week or 2 of starting Varenicline. So it's definitely effective for the patients who can manage the side effects. You do not want to use it for patients with severe renal impairment, who are pregnant or breastfeeding, or who are under 18 years old. And finally, dosing of Varenicline. This is sort of how dosing works. You titrate up gradually. So a person will start with 0.5 milligrams once daily, and then they'll gradually go up to 0.5 milligrams twice daily, and eventually they're at 1 milligram twice daily. And that sort of just helps build it up into their system. You can start to see if someone, for example, once they've moved up to the 1 milligram tablet twice daily is experiencing some side effects, you could drop back down. So I do have some patients who are on very low doses of Varenicline and just stay at the 0.5 milligram tablet once or twice daily. So that is an option too for patients who are experiencing side effects. And then the final FDA-approved medication is Bupropion. This, just to be clear, it is FDA-approved. It is not what we considered standard of care. It's not as effective as the other 2 options we've discussed, the nicotine replacement therapy or the Varenicline. But advantages are that it may attenuate weight gain during treatment, so patients who are really concerned about gaining weight as they quit, or who have gained a lot of weight in the past when they've quit, it could be really ideal for them. It may be beneficial in patients with comorbid depression because it's also an antidepressant, and it's low cost. It's very affordable, and that's the other advantage. Disadvantages are some common side effects like headache, dry mouth, insomnia, and weight loss, and it is contraindicated for patients with low seizure threshold due to a seizure disorder, alcohol dependence, liver disease, anorexia, bulimia, head injury, stroke, etc., and also for those who are pregnant.
All right, we'll activate that next poll now, and that should pop up hopefully in just a minute here. It's active. Okay. No, actually, maybe advance it and then go back one, because for some reason it seems to be having a little trouble grabbing that poll. Try advancing it just one more slide, Steve.
Again.
And then let's go back. Let's see if it's. Wait, it is having trouble there. Let me try something here. See if we can get it to take the poll. It is being obstinate. Let me try. I've got a trick I can do on the computer that may actually help here. Let's go to next. And boy, if you can hand me that for a second. Yeah, like I mentioned, we're trying to to step up our game with the poll everywhere, but I'm not sure we're succeeding. Okay, we're going to jump back to that, and then we'll let's see if.
I suppose while we're reading.
There we go. And again, somebody knew the answer before somebody's fast forwarding this presentation, considering it's live. I'm not sure that's a good idea. So, all right, what medication or medications are considered standard of care for tobacco cessation? And
Varenicline.
A only would be A. Bupropion.
Bupropion.
Okay, for bupropion would be B. Both medications in combination nicotine replacement are both
Varenicline, sorry.
Varenicline and combination nicotine replacement therapy, or both bupropion and combination nicotine replacement therapy. So A, B, C, or D. Go ahead. I'm glad we were able to get the poll showing. So how are they doing?
Doing very well. 100% of people are in the right place.
Including that one who knew it before they'd even seen the poll.
Yes. Okay. So standard of care is both Varenicline and combination nicotine replacement therapy. Those I mentioned before are your go-tos.
Okay.
You should be trying those before you're trying anything else.
Okay, great. Great. Thank you. Thank you, all. And we have 42 people actively involved in the polling, so thank you all.
I got it right.
Great.
Wonderful. Yeah. Okay. Okay, so when you're thinking about making recommendations for medications, you want to think about a few different things. You want to think about what's standard of care, what insurance coverage a patient has, what are some of the limitations of pharmacotherapy, what prior experience have they had with medications, and then what's their preference in terms of medications. So in terms of insurance coverage, this is a big one for a lot of patients at the North Carolina Cancer Hospital. Medicare and some private insurance plans do not cover medications that are available over the counter. So the nicotine patch, nicotine gum, and lozenge, which are available over the counter, a lot of insurance companies will not cover those, so patients have to buy them over the counter, and they can be cost prohibitive for some patients. North Carolina Medicaid and Blue Cross Blue Shield do cover over-the-counter medications with a prescription. So if you can get someone to write a prescription for that patient for the nicotine patch, the nicotine gum, or lozenge, they can get that at a pharmacy either covered fully, or I think Medicaid is like a $3 copay. So that's wonderful for people who have those insurances. And finally, the North Carolina Quitline can provide free nicotine replacement therapy to certain patients. So a lot of times when patients are totally uninsured, they can do that. If a patient has some sort of mental health disorder, anxiety, depression, things like that, they'll cover a good chunk of free nicotine replacement therapy. So you for sure want to consider insurance coverage. You want to consider the limitations of pharmacotherapy. So as I mentioned before, pharmacotherapy addresses the physiological component, but not the behavioral component. And then again, prior experience, patient preference, and standard of care. So as I mentioned before, standard of care is 12 weeks of nicotine replacement therapy or 12 weeks of Varenicline. If patients say it didn't work, you want to ask how they were using the medication, how long they used it for, what technique were they using, were they chewing the gum the way the nicotine gum is supposed to be chewed, where you chew it and park it in the side of your mouth, or were they just chewing it like normal gum? What dosage were they using, and did they have even any success in quitting before? As Colleen mentioned, tobacco is a chronic and relapsing disease, so if they quit before with medication, that actually means the medications worked. There are a lot of myths around medications, like if I use nicotine replacement therapy, I'll just be addicted to something else. As I mentioned before, there's a lower addiction potential. People can titrate down gradually in their nicotine, and it's clean. It's what we consider clean nicotine. It doesn't come with other toxins and carcinogens. People often think if I smoke and use NRT, I'll have a heart attack. The most effective way to use NRT is to start prior to quitting smoking. Actually, that's a pre-quit period, and the FDA does support doing those things. Varenicline makes people suicidal and crazy. Initially, Varenicline did have a black box warning regarding suicide risk and cardiac events, but that warning was removed in 2016 after 2 large trials showed no increased risk. Also, some people think they only have to use medication for a month or until they quit smoking. And even though withdrawal symptoms have subsided at that time, they have to continue using medications while their brain is relearning and developing new pathways. That's why we say 12 weeks or 3 months minimum. In terms of side effects, if someone is having lightheadedness or nausea, you want to bring the dosage down. If they're experiencing withdrawal symptoms like irritability cravings, that's a sign you need to increase the dosage. If they're having trouble sleeping, take off the patch at night, or skin irritation. That's not necessarily an allergic reaction. Nicotine does irritate the skin, so move the patch around from day to day or apply some hydrocortisone cream. Similar dosage issues for gum or lozenge. And for Varenicline, if someone's experiencing nausea, take it with a full glass of water and food. And if they're having trouble sleeping, take that second dose earlier in the day. I guess we'll turn to Colleen now.
Yeah. So as Ellen mentioned, there are some possible side effects that patients can experience with these medications. Overall, we always reiterate that they are safe, FDA approved, which also means they're typically safe as well for oncology patients. There are some things, of course, to keep in mind with regards to a patient going through cancer treatment and these medications. One of the most important ones would be bupropion would not be appropriate for a patient that will be taking tamoxifen. Sometimes they already know that might be part of their treatment plan for cancer. So that might be something you can start them on and then sort of plan out ahead of time that they have completed their 12-week course of treatment on bupropion before the tamoxifen begins. Varenicline, unfortunately, one of the side effects is some nausea, which the patient may already be experiencing because of their chemotherapy or radiation. Something you could explore is an anti-nausea medication, which could kind of kill 2 birds with 1 stone. Also, that low-dose Varenicline that Ellen talked about. They get the benefit of the help with the smoking cessation without some of those negative side effects. Also, to keep in mind, patients that maybe have a head and neck cancer, the gum or the lozenge you might be unable to kind of recommend. That might be something where a minty gum or peppermints could be good, especially if the patient smokes menthol cigarettes. It would give them a similar flavor without some of the irritation of the nicotine gum or the nicotine lozenge. And again, somebody who's maybe having head and neck surgery or head and neck treatment, the inhaler or the nasal spray may cause further irritation. So all of these things are again, safe to use with patients undergoing oncology treatment. They may just require a little extra kind of planning and thinking through with regards to what's a better recommendation than another. And what about patients that aren't ready to quit? As Ellen mentioned, sometimes this pre-quit period can really help patients increase their confidence. That's where they would start the medication, make no other changes, but really start to see the effects that cessation medications can have on urges and cravings. And I think sometimes patients, once they start to see that momentum, their confidence grows. And sometimes it's just getting them over that hurdle to where they can build the momentum moving towards complete cessation. And also, you may want to negotiate even just reduction. Of course, every patient, we hope, quits or becomes completely tobacco-free. But sometimes, a baby step along that way is negotiating, cutting out 2 or 3 cigarettes or a can or a pouch a week, and really help that patient see that they can do this, and then you can sort of nudge them closer to the idea of complete cessation. And refer. Again, if you don't feel comfortable, you don't have the time, there are wonderful resources for patients. The North Carolina Quitline is free and available to all Carolina residents. Smokefree.gov has some wonderful online resources and texting programs. Those might be quite good for patients that live in rural areas or areas that are under-resourced, because they can often access an online resource if they can't get in-person counseling. And the internal resource within UNC is the UNC tobacco treatment program. We have several teams throughout the system, so usually there's one that's a good fit for your patient somewhere. You yourself can always fax a referral to the North Carolina Quitline through Epic. These might be a little difficult to read, but hopefully with the slides that you get after this presentation, it can walk you through. We're always happy to help you figure this out and get it set up within your Epic profile so that you can start sending those referrals as well. And with the North Carolina Cancer Hospital, we are available to patients and their family members. You can send a work queue referral through Epic. It's ambulatory referral to family medicine. Specifically, the department is ancillary services. And if you would like, you can designate Ellen as the recipient of that. And things to keep in mind with regards to working with cancer patients and tobacco use. As Ellen mentioned earlier, they're undergoing chronic and persistent stress because of their cancer care. And stress is probably the #1 trigger we hear about from patients for their tobacco use. And so really working with them to develop and implement positive, healthy coping strategies. It'll be helpful not only for their tobacco use, but also getting through their cancer care in the best headspace possible. Provider attitude. Sometimes, unfortunately, we get providers that don't address tobacco use, especially with end-stage cancer patients. And we do know from experience that even patients with terminal diagnoses have a motivation to want to quit. And so I think it's important to not take that off the table simply because of the prognosis. Proximity to cancer treatment. Many patients are coming from all across the state to get their cancer care here in Chapel Hill, which can make it really difficult for them to feel like they can tackle their tobacco use and get the appropriate support. We offer phone counseling, which I think helps reduce many of those barriers. And, cancer patients probably experience a higher level of addiction to nicotine. This goes to many of the issues with regards to mental health symptoms, other comorbid conditions, which may mean that we have to provide tobacco treatment for a longer course of time than for any other patient that's trying to quit tobacco.
All right. And we did figure out what was going on with the poll. It turns out that the system is advancing to the phones ahead of time. So that's why, even though the poll wasn't active, and now we're already getting the answers. So thank you all so much. And thanks for being patient with us while we figured that out. What is one misconception about tobacco use treatment for cancer patients? And would that be A, cancer patients have higher levels of nicotine addiction? Would that be B, providers have low confidence in their ability to address tobacco use? Would that be C, late-stage cancer patients do not have reasons to quit? Or would that be D, cancer patients need longer and more intense tobacco use treatment?
Looks like they're doing well.
All right, once again.
C, yes.
And thank you to our audience for participating in that. Now, that probably meant for those that were seeing that in advance, you may not have had a chance to plug in questions for the end yet, but that'll be coming up, so everyone will have a chance to share their questions.
Okay, so I'm going to be speaking just really quickly, because I know we want to allow some time for questions, about using e-cigarettes to quit smoking, because I know that's a big question for a lot of people. Essentially, no, do not use e-cigarettes to quit smoking. There are just a lot of risks, as everyone's been hearing in the news, all of the lung injury cases. As of last week, there were over 2,000 that have been reported. There's also a risk of burns from the e-cigarettes or vapes. So it's certainly not something that is recommended. It's not approved as a smoking cessation aid, so we say do not use it. The other challenge is that most people who actually use e-cigarettes or vapes are currently smoking cigarettes. So people end up using both and not actually quitting, even though they're trying to quit one. So that's why we say no e-cigarettes, go with one of the FDA-approved medications. And again, just to reiterate, the 5 A's of tobacco use treatment are ask, advise, assess, assist, and arrange.
All right, and we'll go to the poll everywhere space. There are references on the slides, and of course those are available online. So with that, questions, and we already have a few. Can you expand on dosing and the nicotine replacement therapy for patients that are smoking while using nicotine replacement therapy?
So we say dosing, let's still keep to the, no matter how much they're smoking, still keep to that nicotine matching. So don't adjust dosing, don't decrease dosing because they're smoking so much. The idea of a pre-quit period is that it gives people a chance to see how the nicotine replacement therapy is working as they gradually quit. I hope that answers that question.
Okay, great. And this was actually a question that I had as well about the charts for the nicotine replacement therapy. Those were great in terms of that dosing information. Is that something, of course, those are available on the slides, which are available online and in this video, but are there other places where somebody, if they're thinking 6 months from now, where they have great information, where do I get that?
We do have a smart phrase. We were trying to figure out how to share that smart phrase more broadly, and we don't have it yet. I don't know if there's any way for people to communicate it with us or for us to get information out beyond this presentation, but we'd be happy to share that.
Great. Well, people can certainly contact us, and we'd be happy to share that information out. Let's see. I also wondered, this was in terms of pharmacotherapy. What do you see as the future of pharmacotherapy? Are there some advances that you're hoping for or expecting to see in coming years?
I think the main advance that we're hoping for at this point is for more research on pharmacotherapy around e-cigarettes at this point, because there's not a lot known about how to treat people who are using e-cigarettes with either counseling or pharmacotherapy. So I think we're really hoping to learn more about how to adjust or find new pharmacotherapy to help e-cigarette use.
And it's not that we know that it doesn't work, it's just that the research hasn't been done to prove the efficacy, prove or disprove the efficacy.
It's very much like testing on words, very personalized.
I think so too. Kind of embracing Varenicline and the idea of a lower dose is something we certainly know about, but it's not widely known or discussed. We know it to be effective, just as effective as the prescribed dose, but without those side effects. So I think making that more widely known can be really helpful.
Great. Well, let's see. Let me look and see. We do have one more question here. Here we go. That'll pop up in just a minute. Can a cancer center bill patients' insurance or Medicare for smoking cessation counseling completed by an NCTTP certified RN who is under direction?
Yes, I believe so. Billing is not my area of expertise specifically, but we do use 2 codes for tobacco cessation that I think anyone can use, especially NCTTP certified. That's 99406 and 99407. 99406 is, I think, 3 to 10 minutes of counseling, and 99407 is more than 10 minutes of that counseling. So yes, I believe that person who asked the question should be able to bill those codes.
Okay. And actually, we have time for one more that just came in. Can you speak to the role of adjunct medications, i.e. antidepressants, in treatment of tobacco use?
Sure. Yeah. I mean, I think it's always important to keep in mind if the patient has an outstanding mental health issue. Certainly, something you wouldn't want to do is prescribe bupropion for somebody who has an anxiety disorder. We do know that it can exacerbate some of those anxiety symptoms. So it is good. It's kind of a kill 2 birds with 1 stone. If somebody's got that already existing depression, of course, it's not the standard of care. And so I would always, and I would always encourage a patient to try and get connected to CCSP at the cancer hospital if they've got mental health issues that they're working through. And that would be a good way to kind of do some wraparound support and maybe tie in some of that mental health treatment and support with the tobacco treatment.
People who are depressed or anxious are much more likely to relapse and have a harder time quitting. So if they're getting their mental health addressed, that's huge for quitting tobacco.
That certainly makes sense.
Yeah.
Well, and we have more questions, but we do need to move on here. So let me let our audience know that we do have lectures coming up, always. Cancer in Pregnancy with Dr. Gehrig, November 27th. That's part of our Medical and Surgical Oncology live lecture series, and that includes CME as well as the other certifications. And yes, we are going to be here on the Wednesday, just the day before Thanksgiving, so we don't want to miss a single opportunity to provide you with more relevant information. So we'll be here. If you're already out of town for the holidays, hey, catch the lecture online through our learning portal. And then RN and Allied Health Nutrition and the Aging Brain and Cancer Care with Melissa Walter, and that'll be on December 11th at noon. This year we will be starting in 2020. We'll be changing the names of both of our series. Look for a whole article in our newsletter devoted to both what the new the name changes will be and why we've made those name changes, as well as what the topics will be in 2020. So that's all coming up soon. We have self-paced more lectures online: clinical trial update, head and neck cancer, and Best of ASCO 2019 lung and genitourinary cancers. Both of those are now available in our portal. Cancer Conversations, Vaping, Cigarettes, and Tobacco Use, coming up November 22nd at noon. So with Laurel Sisler. And with that, you know where to find us, unccn.org, past lectures, future lectures, and so much more. So thank you both. We really appreciate it. Ellen and Colleen, this has been great. Thank you to our audience. Have a great rest of your week, and we look forward to seeing you in a couple of weeks. Thanks so much.